And now we're going to have the panel section. So, anyone, any questions, raise your hand and Mary will bring you the microscope, or not the microscope, the microphone.
I won't.
Let's get the other one. Right here. Oh, here.
Is this on? Okay. So great talks, everyone. Thank you for coming. Ted, I had a quick question on corneal hysteresis. Do you believe that it's a risk factor, an independent risk factor for glaucoma, in the same way that CCT is, but it's measuring it in a better way, or do you think they're measuring different things?
Well, I think hysteresis is measuring more than central corneal thickness. So I think it's getting at the measurement error better than the corneal thickness measurement is. I don't believe it's an independent factor because CCT and corneal hysteresis only come out as risks in models that include intraocular pressure or retrospective studies where patients are treated according to Goldman pressures. So I think it's probably not independent. I don't believe there's evidence that the biomechanics put an eye at greater or lesser risk of glaucoma progression or developing glaucoma. It's an attractive thought and it may be true, but I don't think that we've got evidence to show that. So the direct answer to your question is that yes, it's similar to CCT, but I think it's giving us more information. Yeah, either hysteresis or measurements from similar devices, I think, should replace CCT because it's giving us a better risk evaluation, and we're able to compensate for the biomechanics in measuring the intraocular pressure.
Excellent presentation. Question for you. I think if I understood what you said, you're saying that the prostaglandin analogs might be overstating their IOP lowering capability because of their effect on the cornea. Is that effect on the cornea by itself perhaps protective? In other words, is a more flexible cornea IOP lowering in itself? Does it reduce the likelihood of damage?
It's an excellent question, that, and we've sort of hypothesized in the past that the size of the ocular pulse amplitude, the stiffness of the coats of the eye may add to risk, and it's something that we're going to be looking at in the UK GTS data set. It's possible that's the case, but we'll need to, I think, probably to set up some studies specifically to look at that. I mean, it begs the question that when we're evaluating new drugs, though, in the future, we can't really just be looking at the Goldman pressure lowering that those drugs give us. We probably actually need to be looking at visual function outcomes after periods of treatment to see which drugs perform best. So I think interesting times ahead.
With corneal hysteresis, can you describe what you think is happening at the optic disc, whether the hysteresis and how it's affecting exoplasmic flow versus vascular events that are going on at the optic disc?
Yeah, again, it's rather speculative. There was a study actually that Tony Wells did, who's in New Zealand, where he put an eye cup on the eye to raise the pressure and looked at the relationship between movements of the depth of the cup in relation to the hysteresis measurements, and found that there was an association. So it may well be that the biomechanics we measure at the cornea are related to biomechanics that we see going on in the optic nerve head. How they relate to ectoplasmic flow and the like is rather more difficult. Harry Quigley speculated that stiffening the tissues at the lamina cribrosa would protect the eyes in animal models, mouse models of glaucoma. When he did that, he actually found the reverse and found that stiffening of the lamina had a counterproductive effect on glaucoma risk, or the risk of damage. So I think if I were to speculate, and it's a view I've held for a long time, is that more viscoelasticity is probably a good thing. So that means that the rather than if you think of the optic nerve head as a shock absorber, if it dissipates in energy, it's more viscous, that's a good thing. If it's more rigid, more elastic, it takes the energy shock more, and that could be related to damage mechanisms. It's all very speculative, but I would guess that younger, more viscoelastic eyes probably can sustain pressure insult better.
My question is for Dr. Gupta. In your animal model, sheep or mouse, can you give us approximate proportion of the outflow under normal circumstances for lymphatics versus the neuromuscular pathway versus the effective measure?
So, excellent question. Thank you. So, remember, we're looking at models that are under anesthesia that are normal. So, either normal sheep, normal mouse, and the work that I showed of the master student Minhui, where she quantified the distribution and separated the uveoscleral from the lymphatic, etc. In that study, the study had to be stopped at 5 hours because of, there's a certain limit. But in that study, the slopes were all moving upward. And had we continued, we would have expected more. But at that 5-hour mark, 7% was deemed to be lympho. What I'd like to just add, though, is that the lymphatic system, I believe, is something that has huge dynamic range, so that if there's an insult, if there's inflammation, or if there's a need for it to kick into action, that its capacity can be greatly increased. And I would just give you an example. In inflammatory glaucoma that have been measured by Taurus, uveoscleral outflow was increased by several hundred fold. I believe that increase could be explained by an augmentation of the function of the lymphatic system. So while it was 7% in our study, I think, it has to be, it's very difficult to weigh what that would look like in man and under normal and abnormal conditions. Thank you for the question.
So those are all excellent talks, including Alex's. So Neeru, I also have a question about, micropulse versus transscleral cyclophotocoagulation. And so are we doing something bad to the lymphatic system if we're doing, ECP or laser treatment? Or is it that the micropulse perhaps works in a different way? Do you have any thoughts on that?
Well, that's a very interesting question. So when we're doing the ECP, for example, we're basically frying our ciliary processes. We know that the ciliary processes regenerate. That's why you've got to often do it multiple times. So I'm not sure that that's necessarily targeting the lymphatics. I would say that it's possible, again, speculative, that the insult, just the mere insult of tissue containing lymphatics, might turn it on to do something. And so again, it's very speculative, but it's normally it should be a very quiet system that might be turned on by those. But I'm not sure it would directly obliterate, since we're hitting the ciliary processes in that particular instance.
Yeah, question for Dr. Pan. Would you expect Zolska and Robressa to be additive, or would they be canceling each other out in the regular measurement?
I don't think there's any data for that. They are certainly acting on different mechanisms. And it may depend on which, for instance, Robressa. I don't think these biological systems are all or nothing. When we modulate them pharmacologically, there is a partial response. And it is possible that they may be additive, but we don't know until we start using them on clinic patients and study those questions specifically.
So I had one question for James and one for Neeru. James, I was wondering if you could comment on what you think the effects of new drugs will be on the distal outflow pathway. So we're talking beyond trabecular meshwork, and that may have implications with, added to MIGS procedures where you bypass the trabecular meshwork? And then, well, we'll answer that question first.
Well, we are coming to understand that the distal outflow pathway has a whole system of smooth muscles. For a long time, they've actually identified muscarinic receptors and parts of the cholinergic pathway in that system, not really knowing what those things do. But perhaps it's if you look at Joe Schumann studies, that it's such a complex web of network of distal outflow vessels, and there is probably some sort of neural regulation going on there. And these drugs, we are playing a lot with the autonomic nervous system. The Rho kinase inhibitors and the nitric oxide donors provide a separate pathway to some of those, bypassing the neural regulation and acting directly in the cells. So they could, I don't think the studies have been done, but Alex showed Joe Stamer studies. So some of these drugs are actually affecting the distal outflow pathways, and for trabecular bypass, maybe.
Yeah, I'll actually add a comment to that. I mean, what James discussed in his talk was, how things are combining, right? You have all these combo therapies now. We've always had like aqueous suppressants and uveoscleral, and now there's the idea of hitting both uveoscleral or outflow pathways, conventional and uveoscleral, in latanoprost and bunode, as well as rocklatan coming out. And really, this is just the next level of combination, which is basically surgery with drugs. Do some surgeries work better with some drugs as opposed to others? And I mean, it's a interesting avenue now where like why what's the role of the trabecular meshwork in the first place, and what are we losing when we ablate it, right? If you argue that it's there to keep blood out of the eye, you can imagine some of these surgeries may not work in some cases because things are collapsing down distal. So that if you want to promote it, then you could combine MIGS with cytoskeleton relaxing agents to try to open up distal again. So it's all these, with so many therapeutic options now, we have the ability to start looking which of the pairs or trios actually become synergistic.
Another point to add to that is, for the long time we've believed that the meshwork is the key resistance tissue, that bypassing it we would solve all the problems in glaucoma. Now we bypass it, and then we don't see the effects that we were expecting. And that potentially leads to Brian's question, which is that distal outflow system is a whole vascular system on its own. We've been studying the endothelium of this system, and we find it's transitional. It's neither blood vessel nor lymphatic, but it's something in between. And it's not hard to imagine that it's not blood flowing through that or lymphatics. It's a different kind of fluid. It's aqueous humor. And so some of the factors determining control of that are different, and I think we're going to discover it with some of these new drugs.
So I'm going to take the last question now to wrap for the morning session. But of course, all the speakers are available, and so please feel free to ask questions during intermissions and so forth. Dr. Gupta, why do we have so many pathways? Like, why do we need more than one? Is there maybe a evolutionary concept here? Did one come before the other and we got added functionalities?
Great question. I am going to venture to say that, the evolution of our knowledge as it gets closer to understanding the specifics and the differences, and in addition to the wonderful work that you're doing, we're trying to pull and tease things apart rather than putting them all in one bag. It's possible that what we call the uveoscleral pathway, I mean, who really understands the uveoscleral pathway? What we call the uveoscleral pathway might actually be, in part at least, the lymphatics is part of that. It'd be hard to imagine that we would have a uveoscleral pathway that was purely and utterly distinct from what was described earlier to be lymphatics in the ciliary muscle. So how they separate and where the lines are is another question that will take probably years to answer, but we're getting started and there's great hope. So for better understandings and better treatments and more personalized care.